Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 207 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, SNA, a 52-year-old female patient is admitted to the medical ICU with a chief complaint of severe diabetic ketoacidosis, abbreviated as DKA. Her pertinent labs include the following arterial blood gas results: a pH of 6.89, a PaCO2 of 20 mm of mercury, a PaO2 of 100 mm of mercury, and a bicarb of 4.8 milliequivalents per liter, and potassium levels of 4.2 milliequivalents per liter. Based on the American Diabetes Association Consensus Statement on Hypoglycemic Crises in Adult Patients with Diabetes, which of the following would be the most appropriate recommendation for IV bicarbonate and potassium chloride therapy in SNA's clinical scenario? Would it be A. Bicarbonate therapy is not indicated, or B. Potassium chloride 20 milliequivalents stat, then 100 mmol of sodium bicarbonate in 400 ml sterile water at 200 ml per hour for 2 hours? Or C. 100 mmol of sodium bicarbonate in 400 ml sterile water with 20 milliequivalents potassium chloride at 200 ml per hour for 2 hours? Or would it be D. 50 mmol of sodium bicarbonate in 400 ml sterile water with 20 milliequivalents potassium chloride at 200 ml per hour for 2 hours? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. 100 mmol of sodium bicarbonate in 400 ml sterile water with 20 milliequivalents of potassium chloride at 200 ml per hour for 2 hours. 50 mmol of sodium bicarbonate in 400 ml sterile water does not reflect the recommended therapy for adults with DKA and pH less than 6.9, because of the adverse vascular effects from severe metabolic acidosis. Adults like this woman with DKA and pH less than 6.9 should receive 100 mmol of sodium bicarbonate in 400 ml sterile water with 20 milliequivalents of potassium chloride at 200 ml per hour for 2 hours until the pH is above 7. In a patient with DKA and a pH less than 6.9, sodium bicarbonate and potassium chloride should be infused together rather than giving an initial potassium chloride IV bolus followed by a sodium bicarbonate infusion. Bicarbonate therapy is not indicated when the pH is 6.9 or higher. This patient meets the criteria for IV bicarbonate therapy because her pH is 6.89. Please advance to the next question. And the next question reads, JKA, a 77-year-old female patient presents to your accident and emergency department with a chief complaint of altered mental status. She has a past medical history significant for type 2 diabetes mellitus. Her pertinent labs include blood glucose 950 mg per deciliter, sodium levels of 149 milliequivalents per liter, potassium levels of 3.9 milliequivalents per liter, a BUN of 61 mg per deciliter, serum creatinine of 1.4 mg per deciliter, arterial pH of 7.35, serum bicarbonate 19 milliequivalents per liter, and ketones in urine are negative. So my question to you is, which of the effective serum osmolalities and probable diagnoses listed below are consistent with this JKA's presentation? Is it A. 351 milliosmoles per kilogram consistent with diabetic ketoacidosis? Or B. 351 milliosmoles per kilogram consistent with hyperosmotic hyperglycemic state? Or C. 270 milliosmoles per kilogram consistent with hyperosmotic hyperglycemic state? Or is it D. milliosmoles per kilogram consistent with diabetic ketoacidosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. 351 milliosmoles per kilogram consistent with hyperosmotic hyperglycemic state. The effective serum osmolality is 351 milliosmoles per kilogram is equal to into brackets 2 multiplied by the sodium concentration closed bracket plus the glucose concentration all divided by 18. This amounts to 2 multiplied by 149 plus 950 divided by 18. It is not 270 milliosmoles per kilogram. An effective serum osmolality greater than 320 milliosmoles per kilogram is one of the features of hyperosmotic hyperglycemic state abbreviated as HHS. This patient's presentation is consistent with HHS, plasma glucose greater than 600 mg per deciliter, arterial pH greater than 7.3, serum bicarbonate greater than 18 milliequivalents per liter, urine negative for ketones, altered mental status, not diabetic ketoacidosis. Please proceed to the next question. And the next question reads, PAZ, a 46-year-old female patient presented to the hospital accident and emergency department with a 2-day history of weakness, fever, painful urination, suprapubic pain, nausea, and vomiting. She has a past medical history significant for type 1 diabetes mellitus and hypertension. PAZ informs the emergency medicine physician she missed her doses of insulin glargine at bedtime and insulin aspart with meals for the past 72 hours due to illness. PAZ was however able to take her antihypertensive agents, amlodipine, hydrochlorothiazide, and hydralazine, which were initiated 30 days ago. PAZ is given a diagnosis of diabetic ketoacidosis, abbreviated as DKA, and a urinary tract infection. So my question to you is, which of the two well-established risk factors listed below could have precipitated PAZ's DKA? Could it have been A. initiation of hydralazine and insulin non-adherence? Or B. initiation of hydrochlorothiazide and initiation of amlodipine, or C. initiation of hydrochlorothiazide and urinary tract infection? Or could it have been D. initiation of amlodipine and urinary tract infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiation of hydrochlorothiazide and urinary tract infection. Although infections, such as urinary tract infections, are well established as precipitating factors in DKA, amlodipine is not known to precipitate DKA. Thiazide diuretics that impact carbohydrate metabolism, e.g., hydrochlorothiazide, can precipitate DKA. Infection is the most common precipitating factor for DKA, and the urinary tract infection also could have led to the hypoglycemic emergency in this patient. Amlodipine is not known to precipitate DKA. Initiation of hydralazine is not known to precipitate DKA. However, inadequate insulin use is a common precipitating factor in DKA. Please proceed to the next question. And the next question reads, KPA, a 37-year-old male patient presents with lethargy and abdominal pain. He has a past medical history significant for type 1 diabetes mellitus. His pertinent labs include a pH of 7.12, AP, CO2 of 17 mm of mercury, serum bicarbonate of 5.6 milliequivalents per liter, blood glucose of 450 mg per deciliter, a BUN 16 mg per deciliter, serum creatinine 1.3 mg per deciliter, sodium levels of 139 milliequivalents per liter, chloride of 112 milliequivalents per liter, potassium levels of 2.5 milliequivalents per liter. The results of his urinalysis are glucose positive and ketones positive. So my question to you is, which of the following interventions listed below would be the most appropriate in KPA's clinical scenario at this time? Would it be A. Administer potassium supplementation and dextrose before initiating insulin therapy? Or B. Administer potassium supplementation before initiating insulin therapy? Or C. Initiate insulin therapy and potassium supplementation simultaneously? Or would it be D. Initiate insulin therapy without potassium supplementation? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Administer potassium supplementation before initiating insulin therapy. Because of this patient's significant hyperkalemia, that is less than 3.3 milliequivalents per liter, potassium must be supplemented prior to the initiation of insulin therapy. Initiating insulin therapy without prior potassium supplementation would further lower the potassium serum concentration, which would increase the risk for a life-threatening arrhythmia. However, dextrose administration is not recommended because the patient is hypoglycemic with a blood glucose of 450 mg per deciliter. In the management of DKA, dextrose is not added to intravenous fluids until the blood glucose is less than 200 mg per deciliter. Please proceed to the next question. And the next question reads, LAK, is a 22-year-old male patient who presented with hyperosmolar hypoglycemic state abbreviated as HHS, and severe hypovolemia. Your emergency medicine consultant on duty has initiated LAK on IV 0.9% normal saline at 1 liter per hour alongside other appropriate interventions for the past 4 hours. Pertinent labs performed at the end of this 4-hour period are as follows. blood glucose 225 mg per deciliter, a BUN of 14 mg per deciliter, serum creatinine of 1.2 mg per deciliter, sodium levels of 147 milliequivalents per liter, and chloride 100 milliequivalents per liter. So my question to you is, which of the IV fluids and infusion rates listed below would be the most appropriate for LAK at this time? Would it be A. 5% dextrose with 0.45% sodium chloride solution at 150 ml per hour? Or B. 0.9% odium chloride solution at 500 ml per hour? Or C. Lactated ringers at 500 ml per hour? Or would it be D. 0.45% sodium chloride solution at 150 ml per hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. 5% dextrose with 0.45% sodium chloride solution at 150 ml per hour. When the blood glucose declines to 300 mg per deciliter or lower in patients with HHS, the IV fluid should be changed to 5% dextrose with 0.45% sodium chloride solution at 150 to 250 ml per hour. Therefore, it is inappropriate to change the IV fluid to 0.45% sodium chloride solution at 150 ml per hour for this patient whose blood glucose is 225 mg per deciliter. It is inappropriate to change the IV fluid to lactated ringers at 500 ml per hour for this patient whose blood glucose is 225 mg per deciliter. It is inappropriate to change the IV fluid to 0.9% sodium chloride solution at 500 ml per hour in this patient whose blood glucose is 225 mg per deciliter. The IV fluid should be changed to 5% dextrose with 0.45% sodium chloride solution at 150 to 250 ml per hour. Therefore, changing the IV fluid to 5% dextrose with 0.45% sodium chloride solution at 150 ml per hour is appropriate for this patient. Please proceed to the next question. And the next question reads, RPA, a 52-year-old female patient weighing 60 kilograms, presents to the accident and emergency department with a chief complaint of nausea, vomiting, and lethargy. She has a past medical history significant for type 1 diabetes mellitus. She has no known drug or food allergies. RPA informs the emergency medicine consultant she missed a few doses of her insulin glargine. Her pertinent labs include a pH of 7.26, AP, CO2 of 16 mm of mercury, serum bicarbonate of 13 milliequivalents per liter, blood glucose 616 mg per deciliter, a BUN of 32 mg per deciliter, serum creatinine 1.1 mg per deciliter, sodium levels of 132 milliequivalents per liter, chloride 102 milliequivalents per liter, and potassium levels of 4.5 milliequivalents per liter. Her urinalysis result include ketones plus. Her pertinent vitals include a body temperature of 100.5 degrees Fahrenheit, a heart rate of 120 beats per minute, a respiratory rate of 25 breaths per minute, a systolic blood pressure of 85 mm of mercury. So my question to you is, which of the regimens listed below would be the most appropriate initial insulin therapy in RPA's clinical scenario? Would it be A. Insulin Lispro 6 units subcutaneously stat, then insulin Lispro 3 units subcutaneously every 1 hour? Or B. Insulin Lispro 18 units subcutaneously stat, then insulin Lispro 6 units subcutaneously every 1 hour? Or C. Regular human insulin 2 units per hour by continuous IV infusion? Or would it be D. Regular human insulin 8 units per hour by continuous IV infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Regular human insulin 8 units per hour by continuous IV infusion. Based on recommendations from the American Diabetes Association consensus statement regarding hypoglycemic crises in adult patients with diabetes, regular human insulin 0.14 units per kilogram per hour by continuous IV infusion can be initiated if an IV bolus is not provided for a patient with diabetic ketoacidosis. This patient has DKA and weighs 60 kg. Therefore, the correct rate for the IV infusion is 8 units per hour, that is at a rate of 0.14 units per kilogram per hour multiplied by 60 kilograms. Regular human insulin 2 units per hour by continuous IV infusion would be inadequate initial therapy for this patient who weighs 60 kilograms and requires 0.14 units per kilogram per hour, which amounts to 8 units per hour. Her blood glucose is 616 mg per deciliter. After it falls below 200 mg per deciliter in patients like this one with diabetic ketoacidosis, the insulin infusion rate can be decreased to 0.02 to 0.05 units per kilogram per hour, which amounts to 2 units per hour, which is approximately 0.03 units per kilogram per hour for this 60 kg patient. Critically ill patients with diabetic ketoacidosis and hypotension like this patient should be treated initially with IV regular human insulin, not subcutaneous insulin. Please progress to the next question. And the next question reads, in which of the clinical scenarios listed below in which patients have received 5 days of antibiotic therapy for severe community-acquired pneumonia (CAP) may treatment be discontinued? Is it A. Patient PSZ, who is febrile, with a heart rate of 70 beats per minute, a respiratory rate of 20 breaths per minute, a systolic blood pressure of 125 mm of mercury, arterial oxygen saturation 94% on room air, eating a normal diet, alert and oriented? Or B. Patient PLR, who has been afebrile for 24 hours, with a heart rate of 80 beats per minute, a respiratory rate of 24 breaths per minute, a systolic blood pressure of 120 mm of mercury, arterial oxygen saturation 96% on room air, eating a normal diet, alert and oriented? Or C. Patient GTE who has been afebrile for 72 hours, with a heart rate of 110 beats per minute, a respiratory rate of 23 breaths per minute, a systolic blood pressure of 85 mm of mercury, arterial oxygen saturation 97% on room air, eating a normal diet, alert and oriented? Or is it D. Patient LCM who has been afebrile for 48 hours, with a heart rate of 90 beats per minute, a respiratory rate of 22 breaths per minute, a systolic blood pressure of 115 mm of mercury, arterial oxygen saturation 95% on room air, eating a normal diet, alert and oriented? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Patient LCM who has been afebrile for 48 hours with a heart rate of 90 beats per minute, a respiratory rate of 22 breaths per minute, a systolic blood pressure of 115 mm of mercury, arterial oxygen saturation 95% on room air, eating a normal diet, alert and oriented. The minimum duration of antibiotic therapy for CAP is 5 days. Therapy may be discontinued after 5 days if the patient has been afebrile for 48 to 72 hours and has no more than one sign of clinical instability: tachycardia, that is a heart rate above 100 beats per minute, tachypnea, that is a respiratory rate above 24 breaths per minute, hypotension, that is a systolic blood pressure below 90 mm of mercury, hypoxia, that is an arterial oxygen saturation below 90% or ApO2 below 60 mm of mercury on room air, no oral intake, and altered mental status. Patient LCM has no signs of clinical instability and has been afebrile for 48 hours, so antibiotic therapy may be discontinued. Patient GTE has 2 signs of clinical instability, that is, tachycardia and hypotension, so antibiotic therapy should not be discontinued. Patient PLR has not been afebrile for 48 to 72 hours, which is required for discontinuation of antibiotic therapy for CAP. Patient PSZ is currently febrile. Antibiotic therapy for CAP should be discontinued only if the patient has been afebrile for 48 to 72 hours. Please proceed to the next question. And the next question reads, ALP, a 75-year-old female patient is admitted to your medical ICU for management of respiratory distress and she urgently requires mechanical ventilation. Her chest X-ray shows a right lower lobe consolidation consistent with pneumonia. She has no known drug or food allergies. She has a past medical history significant for COPD. So my question to you is, which of the IV therapies listed below would be the most appropriate for ALP's community-acquired pneumonia, abbreviated as CAP? Would it be A. levofloxacin plus cefepime, or B. vancomycin plus cefepime, or C. azithromycin plus ceftriaxone? Or would it be D. levofloxacin plus ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. levofloxacin plus cefepime. Ceftriaxone plus levofloxacin is not recommended for empiric treatment of CAP in ICU patients at risk for infection with Pseudomonas aeruginosa. This patient is at risk for pseudomonal infection because of her COPD. Ceftriaxone is inadequate. This patient must be treated with an anti-pseudomonal beta-lactam antibiotic, such as cefepime or piperacillin tazobactam. Ceftriaxone plus azithromycin is not recommended for empiric treatment of CAP in ICU patients at risk for infection with Pseudomonas aeruginosa. This patient is at risk for pseudomonal infection because of her COPD. Ceftriaxone is inadequate. Cefepime plus vancomycin is inappropriate for this patient because she does not have risk factors for MRSA. Therefore, vancomycin therapy is not indicated. This patient has severe CAP because of her acute respiratory distress requiring mechanical ventilation. COPD is a risk factor for Pseudomonas aeruginosa. Recommended empiric antibiotic therapy for intensive care unit patients with CAP and at risk for infection with Pseudomonas aeruginosa include antipneumococcal, antipseudomonal beta-lactam antibiotic plus a respiratory fluoroquinolone. Therefore, cefepime plus levofloxacin is an appropriate choice for this patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 208.